And we're recording.
Welcome to today's FSHD 101 webinar from the FSH Society. Our speaker today is Dr. Samantha LoRusso. She's an assistant professor of neurology at the Ohio State University Wexner Medical Center in Columbus, Ohio. She worked closely with Dr. John Kissel at OSU, and for those of you who follow research in FSHD, he's been one of the major figures in clinical research on FSHD and in other muscular dystrophies. And now Dr. LoRusso is the site principal investigator for the FSHD Clinical Trial Research Network, and OSU is one of the sites of the network. So she's very familiar with FSHD, but she's also been there, how many years now?
About 2 years.
2 years. So in our field, a fresh face, and we're excited to introduce you all to Dr. LoRusso. So with that, I will turn over the mic, as it were, to Dr. LoRusso. Welcome.
Thank you so much. Thank you and so much for having me and for letting me give this presentation to everyone. And hopefully everyone is going to learn something today. And if not, hopefully this will be a good review. So let's go ahead and get started. So we're going to start with an overview of FSH, and this is just a list of our objectives. So we're also going to try to touch on molecular pathogenesis and then talk about the clinical presentation, approach to management, and finish up with talking about research and clinical trials. So starting with that history lesson, FSH was first reported by Duchenne in 1869. And yes, this is the same Duchenne whose namesake is on another muscular dystrophy. The picture on the right is of a child thought to have FSH from one of Duchenne's publications. And then in 1885, Landuzzi and Desjardins detailed the features of FSH. And I apologize to anyone who I offended with my pronunciation there. And then it wasn't until about 100 years later, in 1982, when Padberg wrote the first modern clinical description of FSH. And then in the 1990s, there was a large natural history study that was completed, and trials on muscle strength in FSH were started around then. And then in 2000, it wasn't then until 2010 that there was a unifying genetic model that described FSH. And then I kind of put this on here. We're kind of wondering when the first disease-modifying treatment is going to be available, but hopefully very soon. So how common is FSH? It's the third most common muscular dystrophy, and then with a prevalence of about 1 in 15,000. Now, if you look at different sources, this number is going to be different almost anywhere you look, just depending on the population that was studied. So moving on, we're going to try to touch on molecular pathogenesis. And warning here, there may be some confusion ahead. This is a very confusing genetic mechanism. And really, truly, the disease pathogenesis is not 100% understood yet by anybody. So there are two types of FSH. There's type 1 and type 2. Type 1 accounts for about 95% of patients and type 2 about 5%. In type 1, the inheritance is dominant and with variable symptoms and penetrance, just meaning that not everyone with the genetic abnormality shows clinical signs of disease. So if you have FSH type 1, then there's a 50% chance of passing it down to a child, or a 50% chance of the child being totally unaffected. FSH2 is a little bit more confusing genetically. It's what we call a digenic inheritance. And to put it simply, you need two variants and two different genes to have the disease. And so if you have FSH2, assuming that your partner is someone without any genetic abnormalities like would be an FSH2, then a child would have 25% chance of getting the disease, a 50% chance of being an asymptomatic carrier, and a 25% chance of being totally unaffected. And more about the genetics. So with this, about 70 to 90% of people will inherit the genetic abnormality from a parent. but actually about 10 to 30% of patients will have FSHD as a result of a totally new or sporadic mutation. So more about pathogenesis. So if you don't remember anything, just try to remember the bottom line here, which is that DUX4 gene expression is toxic to muscle. So in FSHD, DUX4 is turned on and is toxic to the muscle, and it's a gene that is usually expressed in early development and then turned off. But in FSHD, it's turned on abnormally, and again, just to repeat myself, the expression of it is toxic to muscle. So taking this a couple steps back again, so the problem is located on chromosome 4, and there are these things called D4, Z4 repeats on chromosome 4. And within these D4, Z4 repeats, there is that gene called DUX4 or double homeobox 4. And for both FSH1 and FSH2, this DUX4 gene turning on is the cause of the disease, but the pathway to getting that gene turned on is different in type 1 and type 2. And going into further detail about the pathogenesis of FSH type 1, there are a reduced number of D4, Z4 repeats. So folks normally have about 11 to 100 of these repeats, but in FSH, people usually have between 1 and 10 repeats. And then in addition to those decreased repeat numbers, you have to have what's called this A polyadenylation sequence after the last repeat. And so in the normal population, people will either have this A sequence after the last repeat, and about 50% of people will have a B sequence. But in FSH type 1, you really need a decreased number of repeats and happen to have that A sequence after the last repeat. And what that does is allow the DNA structure to loosen up, open, and allow DUX4 gene to be turned on. And then this is a diagram trying to explain all of this. So if you look at the top where it says normal in blue, so this is where people normally have 11 to 100 of those D4, Z4 repeats, and then DUX4 is not turned on. And then, or you can have a decreased number of repeats, but then have that B hanging out next to them as opposed to an A, and then you're still fine and have no DUX4. Whereas opposed to an FSH1, just look at the first row there next to the yellow, you have a decreased number of repeats, an A after that, and then you make abnormal DUX4. So FSH type 2 is a little bit more confusing because there is a normal number of repeats, and normal, but still usually less than 26. And that DNA structure is loosened, DUX4 is turned on, but the loosening of the DNA structure and causing that DUX4 to be turned on, actually you need another thing to happen. You need an abnormality in a different gene. So it can, with our current knowledge, we think that this occurs either in the SMUSH-D1 gene or the DMMT3B gene. And then interestingly, it's been found that these genes are also modifiers for disease severity in FSH1. And so this is how all of you might be feeling right now. Maybe scared, confused. This is my dog. I just had to find some way to get him into this presentation. And then, or maybe everyone's falling asleep by now, in which case maybe time to wake up. We're gonna start talking about the clinical presentation. So this disease is named for the muscles that are most commonly affected, the face, the shoulder blades, and the upper arms. And so with facial weakness, people usually notice difficulty smiling, difficulty whistling, may have difficulty closing their eyes. People who sleep with them might notice that their eyes aren't closing completely at night. And then the problems with the scapula or the shoulder blades cause difficulty with lifting arms up overhead. And then, so looking at these pictures here, the top one on the right is just showing decreased muscle bulk in the biceps and triceps, which are muscles that are commonly affected, with actually this person's deltoid, which is that shoulder muscle, looks fairly good compared to the biceps and triceps. And then looking at the picture on the bottom on the left, this man has a lot of pectoral atrophy. And so what we notice when we see people in clinic are this line between the torso and the arm looks more horizontal. That crease there looks more horizontal than it should. It usually looks more vertical, which we call a horizontal axillary line. And again, that's just happening because the pectoral muscles are weak there. And then if you look at the picture on the bottom right, this is scapular winging that you see there on the left. And this lady has also had a scapular fixation surgery, which we'll talk about later, but that's what that scar is on the right. And just as a side note, so the weakness is often asymmetric in FSH. So other commonly affected muscles are the muscles that line the spine and the abdominal muscles. So this can lead to problems with abnormal posture, difficulty sitting up from lying down, loss of balance, and pain and fatigue, which we'll talk about a little bit later. And then also people can have problems with leg muscles, especially with the muscle that leads to foot drop, so causing some difficulties with tripping while walking. But then usually later people can also have problems with the muscles up in the upper leg or in the hip girdle. So they can notice difficulty going upstairs or walking long distances or difficulty rising from a chair. Less commonly affected muscles are the bulbar muscles, which would affect swallowing and voice, and respiratory muscles like the diaphragm. So there have been several studies, and I apologize, this is not every study here, but there have been even several recent ones which show about 10% of patients do have respiratory involvement, and about 1 to 8% will require ventilatory support at some point. So, and then there are also some non-muscle involvement. This is mainly FSH1, and in people with FSH1 and very few repeat sizes. So high frequency hearing loss can occur. It usually is subclinical, except for in those cases of very early onset in children. You really have to monitor this. Also can have problems with blood vessels in the eyes, and it causes a retinal disease, sometimes termed Coates disease. And this again is super uncommon in FSH, and it's mostly occurring in people who are more severely affected. And then with regards to cardiac disease, this has been looked at and is usually mild and usually comes in the form of arrhythmias, and it's almost always asymptomatic. So other common symptoms are pain and fatigue. Pain has been shown to be present in over 3/4 of patients. And for management, we'll talk about this a little bit later again too, but for acute pain, generally using nonsteroidal anti-inflammatory medications like ibuprofen, Aleve. And then for more chronic pain, we choose medications usually in the antidepressant class or anti-seizure class, like Cymbalta, Lyrica, you may have heard of. As far as disease progression, we do consider this a slowly progressive disease, but there is a high variability, and I'll probably say this a couple times. So you can have high variability within families, and even there's been shown to be variability within identical twins. And within the same patient, I also just wanted to stress that there can be a lot of variability between muscle groups. So, we talked about that asymmetry, but on the left side could have a biceps that's totally gone and then really have not a lot of weakness elsewhere, or even have come in with a foot drop and not have a ton of scapular weakness. All of that is possible. And so because of all this and the variability, it's very difficult to predict an individual's disease course. And then also I wanted to point out that although we consider this a very slowly progressive disease, often patients and physicians notice sometimes a stepwise progression, meaning that patients can feel like they're doing fine for from years or over a year, and then all of a sudden feel like a muscle just gets weak pretty quickly over a period of weeks or months. The majority of people will show signs of the disease by age 20 or 30, with that number being in general, a little bit later for women compared to men. And about 10% of patients will have an earlier onset disease, meaning before age 10, and generally earlier onset disease is associated with more severe disease. And about 20% of people will have to use a wheelchair for ambulation by age 50. But in general, there is a normal life expectancy. The only reason that I can think of that would make life expectancy less is if there was severe respiratory involvement, which can happen sometimes. So some modifiers of disease severity. So going back to that D4Z4 repeat size, that does seem to be important. So very short D4Z4 repeat sizes, like from 1 to 3 repeats, is associated with earlier onset, more severe disease. And then less severe disease is pretty clearly associated with higher repeat sizes in the range of 7 to 8, 7, 8 to 10. And even there are some people who are asymptomatic within this range. And then in between that, say from 4 to 6 or 4 to 7 repeats, that's where we in general see that super high variability. And then just going back to the gender differences, it has been shown that a higher proportion of women, for reasons that aren't completely understood, are more likely to be those asymptomatic gene carriers. So moving on again, so now we're going to talk a little bit about management and things that we recommend to folks. So just before we get into this, if anyone wants to look into this further, I still think that these guidelines are very relevant, published by Dr. Twill back in 2015. And so if maybe look online and find that if you want more details. But as far as limb and back pain, again, we're thinking about using non-steroidal anti-inflammatory medications for acute pain and more of the antidepressant and anticonvulsant medications for chronic pain. And then we do recommend physical therapy, which we'll talk a little bit more about later. And then using bracing to help with pain is also helpful. So this woman here is using a lumbosacral corset or binder for her abdominal weakness, and that weakness with the muscles along the spine. And so talking more about bracing, so for people who have foot drop, we often recommend AFOs or ankle foot orthoses. And this is less common in FSH, but they also do make braces that go above the knee for people who have more weakness in their upper leg. And then there are scapular retraction orthotic devices. I actually don't see these being used a lot. They can be helpful for pain, and they can be helpful in certain situations, like if you have a young kid who's playing sports, might benefit from wearing one of these during a game. They're not often, I haven't oftentimes seen people use them 24 hours a day. And from what I understand, they don't give you much extra mobility compared to what we will talk about next, which is actually doing a scapular stabilization surgery. So this is a surgery done by an orthopedic surgeon, definitely not by a neurologist, where the surgeon fixes the scapula to the chest wall. And this basically allows a person to have more movement, more ability to lift their arm above their head. Sometimes in the clinic, we can do a clinical bedside test to try to see if a surgery would have a good result. We actually manually stabilize the scapula by pushing in on it and see if patients can get a better range of motion by doing that. And so usually the surgery is recommended more for people who have otherwise good arm strength. So mainly weakness in the scapular muscles, but otherwise very good. And then this is a huge surgery, can't emphasize that enough. There are possible complications, which I've listed here. There is a long period of immobility. So really you need a motivated patient and a very experienced surgeon. So on to talking about physical therapy. So aerobic exercise is recommended, and we're always going to say under the supervision of a physical therapist. It definitely appears to be safe and potentially beneficial. So I would encourage things like water therapy, using a stationary bike. And then with regards to strength training, there's no data to suggest that strength training is detrimental. And again, this should really be done at least with an initial consultation with a physical therapist who's familiar with FSH. But more, we're thinking low, medium resistance programs. So more of that high rep, low weight, and not the super high weight. And then I thought that some people might have a question about neuromuscular electrical stimulation. This is a thing that's out there and may be helpful, especially for those who can't really participate, who are very weak or can't participate as much in the other types of physical therapy. But there has been one study published on this, but it was very small, and I would just say that the jury's out a little bit on this for now. So we are almost done. So research and clinical trials. So here are some prior clinical trials that have been done. So again, dating back to the 1990s all the way, I have on here through 2015, although this list is by no means exhaustive. So I'm mainly listing things that I've tried as far as interventional studies. And unfortunately, none of these showed a significant response, but I did have, there are a couple caveats in there. Some of these studies were not powered to look for efficacy necessarily, and some of these studies did show some signal in secondary outcome measures, but the primary outcome measure was not significant. And so I just wanted to say for everyone to at least consider getting involved, and obviously most of you are involved already because you're on learning about FSH, but there's tons of research happening and all different types. So there's preclinical research, and they need volunteers to give blood, provide muscle, skin samples, get imaging. And then there are observational studies, which we'll talk about one in a second, where there's no clear intervention given, but patients are usually watched over time. And then there are interventional studies where people are given drugs or even physical therapy, and then you look at the outcome. So the exciting thing is that there are expected to be many more of these intervention type studies over the next 5-10 years. So I just wanted to put in a plug for the RESOLVE study. So this is currently enrolling. It's in 8 sites in the United States and 3 in Europe. It's an 18-month observational study. So again, with this one, we're watching patients over time, but there's no specific intervention. And the overall goal of this study is to hasten drug development for FSH by validating new clinical outcome assessments and refining trial planning strategies. So the reason for this study is really that there are a lot of challenges in FSH drug trials, the main ones being the rarity of the disease, trying to find enough patients to be involved in trials, and also because of what we had talked about previously, that slow disease progression, and because it's variable between patients, that actually leads to some issues with trying to decide whether a drug is efficacious or not. So if you think about a typical drug trial timeframe is over 1 to 2 years. And if you have people who are only losing a little bit of strength over 1 to 2 years, it can sometimes be hard to see whether a drug, for instance, is stopping disease progression or not. All right, so some other words about just a couple other studies. And so there's this one that many of you guys are familiar with, ACE-083. This is an injection that they put, an intramuscular injection that they're looking specifically at the biceps and the tibialis anterior muscles. Tibialis anterior is the muscle in the lower leg that allows you to bring your foot back. And the overall goal of this is to increase muscle mass and strength in the muscle where the drug was given. And I just wanted to point out that this trial is a more generic type of approach. This is not specific to FSH pathology. For instance, this drug is also being tried in something called Charcot-Marie-Tooth, a genetic neuropathy. And so this is, again, currently ongoing, but not currently enrolling. And then just a word about some stuff for the future. So this is super exciting, and I'm sure most of you saw this announcement, but Fulcrum Therapeutics has announced that they are going to have a phase 2 trial of this drug called losmapimod in mid-2019. And this is kind of cool because it's a drug that's been repurposed. So it's an oral drug that's been previously looked at in many people, so over 3,000 people, but it was looked at for many different indications, totally different, like cardiovascular disease, COPD. The good news is that it's overall well tolerated. And the reason why Fulcrum is looking at this drug for FSH is that in preclinical studies, it was found that the drug actually decreases DUX4 gene expression. So again, this is actually super exciting, and really for the reason this is going to be the first trial that's looking at a drug that gets at the FSH disease mechanism. And looking forward to the future, I'm just going to talk a little bit about gene therapy here. So there have been other neuromuscular diseases that have recently been helped by types of gene therapy. And I just wanted to put in one plug for Dr. Scott Harper. He's a research scientist here in Columbus, and he's doing a lot of good work looking into possibly for gene therapy for FSH as far as silencing the DUX4 gene. So this is all preclinical currently, but hopefully in the coming years, this is going to go into a clinical drug trial. And I think we are almost done. So where to find more information about clinical trials? So look at www.clinicaltrials.gov or maybe start at the FSH website here. I think that they did a really great job of listing off the studies that are currently enrolling, or the ones that are active, and describing them. And also with both of these websites, they give you a contact information on who to contact if you're interested in hearing more about it. And now I think we're done. We are totally done, and hopefully you guys learned something and have some questions. I just wanted to say thank you to June and the FSH Society for inviting me to talk about this. And then of course, thanks to Dr. Kissel, and then also our physical therapists and genetic counselors here at Ohio State, Doug Eck, Christina Kelly, Jennifer Rogenbuck, and Wendy King. And just before I forget, with Wendy King reminded me, there's also an excellent link on the FSH Society website going to a pamphlet that Wendy King made about physical therapy and FSH. And then also a big thank you to Doctors Jeffrey Satland and Robbie Twill and the whole FSH Clinical Trial Research Network. So thank you. And now we all should be happy.
Thank you so much. That was really informative. So we have a lot of questions coming in, and if, everybody, if you have other questions, please type them in using the Q&A link. That's the one I'm reading off of. I saw a few people post in the chat link. If you did that, please repost it in the Q&A link so that I can, it just helps me manage this process. So I'll go to our first question from a listener who said, my dystrophy did not present until menopause, age 50. Will it progress differently from those who develop symptoms at puberty?
Yeah, so this is a great question, and I'm going to do a lot of hand waving probably with some of these questions, but we really don't 100% know the answer. I'd say that for sure the disease progression is likely to be, you're likely to have less severe disease just because you had a later onset as opposed to a really early onset like in puberty or before age 10. And then it's interesting that you mentioned the menopause thing, because there is some thought that maybe there is some relation to hormones and estrogen with FSH, but it's really not completely understood. But overall, yes, I guess is the answer, that I would see that as a positive thing that you didn't have symptoms until that late.
Thanks. Another question. FSHD runs in our family. 3 of my siblings, including me, have the same deletion that indicates FSHD, and yet one of us has no symptoms. I presented at age 50 and our brother presented at 13. Why is that? Do we have other genetic differences, or are there unknown factors involved?
Yeah, so both of those things. So there are lots of unknown factors. So like I said, this is a pretty common thing that happens, where you have people who are pretty severe in the same family and then have someone with the same thing who's totally asymptomatic. So that's not unusual, but that is what we are really trying currently to understand better. So we think that it is related to possibly other genes that haven't been identified, or just other environmental factors.
Can you say something about the importance of families like this to get involved with research, and where should they go to participate in a study like that?
Yeah, so this is really important, and I would just, as far as where to go, I would just look on clinical trials and kind of look for a place close to you and kind of look through. There are some studies that are specifically looking at these genetic differences. So I apologize, I don't know exactly which study to recommend offhand, but there are quite a few that are trying to dive deeper into understanding the genetics, like you're suggesting.
Okay, and I think a related question is people want to know if there are protective factors. And
yeah, so again, this is a big generality, but we think to some degree, being a woman may portend a better prognosis, and why that is still not completely understood. And as far as other protective factors, I don't know anything right offhand, but that is again something that people are looking into. So does that person, and like you're saying, in the family who's totally asymptomatic, was there something in their genes or otherwise that protected them? And really, I just don't think we know the answer.
All right. So we have some questions about some of the clinical presentation. There was a question about the chest wall collapse or loss of chest wall muscle.
Mm-hmm.
You mentioned that in your presentation. I'm wondering.
Yeah, so what I talked about was how people pretty commonly have pectoral muscle weakness, but I'm not sure if this is what the person was getting at. Sometimes there is an association between actually a change in the way the chest wall looks that's not just the pectoral weakness. And I don't want to say it wrong, but it's called pectus excavatum. So it's just another thing that has been associated with FSH, but it's not exactly the same as what I showed before with the pectoral weakness.
Yeah. I've heard that before too. Can you talk a little bit more about what is pectoral excavatum?
So to be honest, I don't completely understand it. It's something that we see just in the general population anyway. So some people have this deformity in their chest wall, sometimes usually where the chest wall kind of goes inward. And that's just, like I said, seen in the normal population in patients without FSH, but people have noticed an association that if you have FSH, you're more likely to have that. But I don't think that there's any more kind of meaning that we know about with regards to that, other than that there is this association there.
Okay. So now what can be done to alleviate shoulder displacement where the joint has begun to separate?
Oh, geez. So then I would that's where I would really talk to the physical therapist and see if it's probably that the muscles around the joint are very weak. So there might not be much that can be done with regards to trying to get some of that strength back with physical therapy, but it might be helpful to talk to a physical therapist and see if there are any muscles that they can target for therapy. In addition, that's where I think that it might be helpful to talk about some of the bracing options to help with that. Otherwise, I'm not familiar with any sort of surgical techniques that could help with it.
Mm-hmm. And you alluded a bit to this in your talk too, but what about patients experiencing lordosis?
Yeah, so lots of abnormal postures. So it's lordosis or other types of abnormal postures, but really for the lordosis, I think that the bracing, what we showed, the lumbosacral corset is usually the best option, even though it's not always. It just depends on how comfortable the patient is in it.
Okay. So this is again related a little bit to sort of skeletal and postural issues, but someone wondering whether FSHD exacerbates osteoporosis. And I think there's been some thought maybe that with loss of muscle strength, we know that
so
is important. So how does that enter?
Right. So this is another connection that people don't understand super clearly. But in muscular dystrophy in general, we find that people have more bone loss than normal people or people without muscular dystrophy. And it's, I think that it probably just has to do with the fact that the muscles are weaker, and it somehow leads to that. But again, this is just one of those things that association is there, and I'd say it's across muscular dystrophies. And I'm not sure how well that's been studied specifically in FSH, but it's been very well looked into in Duchenne muscular dystrophy and some of the others, and it's still something. I'm sorry that I'm just going to keep repeating this, that we don't entirely understand.
All right, so here's another question I commonly hear, that patients are worried that if they start using braces, that their muscles will weaken probably faster than they would otherwise because they're maybe being supported and not getting the exercise and use that people think they need. How do you address that?
So I really, I would talk to the physical therapist about it, but I really wouldn't think that that's true. So usually, we're using bracing because muscles are usually extraordinarily weak by the time we're using a brace. So for instance, for the AFOs, we're using that for the dorsiflexion weakness, and usually the muscle is pretty bad by that point, by the time you're putting a brace on it. So probably what you're doing in normal life is exercising that muscle that's super weak to begin with. Probably everything that you're doing in normal life is already exercising it to the max. So I don't think that putting on a brace is going to make a huge difference. And I think that basically what I'm saying is I think that already with those super weak muscles that you're using a bracing for, you're probably already getting enough exercise for them. And so I really don't think that putting a brace there is going to be harmful.
Mm-hmm. And it's not an either or. It's not like if you start using braces, you stop exercising.
No, exactly.
Right. So this is another very common concern. It's kind of related. Someone has a very physical job, and is that going to speed up muscle loss, or is it going to help retain muscle?
Mm-hmm. We don't know the exact answer to that. So again, there have been studies where they've specifically looked at strength training, and it doesn't seem to be detrimental, but still we get nervous about recommending a lot of high intensity strength training, because it does seem like it probably would break down the muscle faster if you did it, if you were very intense. And so I really think that is just kind of see how things go over time with that. Talk to a physical therapist. It really depends on how weak the muscles are, and then how much you're doing, and really a detailed discussion about that on whether it may be too much or not. But yeah, it is something to consider. Although overall, I would still tend to promote more exercise, but there is definitely a point where I think it's much. It's thinking about how much are you actually doing throughout the day, and then how weak are the muscles.
So let's move on to some other non-muscular symptoms people are asking. A question saying, and said tooth pain. I don't think that, maybe they misheard. And hearing loss were briefly mentioned. Are these common symptoms?
Yeah, so I don't think that anything with the teeth is associated with FSH, but yeah, so hearing loss. So we talked about the high frequency sensory neural hearing loss has been found in many patients, but generally this is asymptomatic. So people don't don't usually have problems with this. And to be honest, I don't routinely send people for hearing evaluations unless they're complaining about it or unless they have really severe disease, just to check. And with FSH, like I said, the concern is really in the kids with very severe disease where they're developing and might have significant hearing loss. We really want to get them in to see somebody soon. But usually it's not very severe and it's often asymptomatic.
Mm-hmm. Actually, it occurred to me with regard to teeth, if you lose muscle around your mouth, can that cause teeth to become displaced and you should maybe go see an orthodontist? Or?
I don't think so.
Yeah, okay. A question, how common is thoracic outlet syndrome with FSHD?
Oh my gosh. So I'm not going to be able to answer this. So I think that the big thing here is that thoracic outlet syndrome in and of itself is not a well understood thing. And a lot of times people say thoracic outlet syndrome when sometimes neurologists might not necessarily think that it's truly thoracic outlet syndrome. So I think that's opening a huge can of worms just because thoracic outlet syndrome is a very difficult thing to diagnose. And a lot of people will get that diagnosis just because they have pain or symptoms when they lift up their arms. And so, gosh, I really can't answer that. I do not think that, I haven't seen that it's that true thoracic outlet syndrome, which again has all kinds of different forms, has been associated with FSH. But it's a great question because, you know, you'd think with the abnormalities in the muscles and the way your shoulders are that maybe that people would have more of a problem there. But I don't know the answer to that.
Okay.
So I guess I will just put an aside there. So not thoracic outlet syndrome, but what we do sometimes, oddly enough, see, and this is just kind of case reports type of thing, but sometimes we do see brachial plexopathies, or we think we see them more commonly in FSH. And so a brachial plexopathy is a problem with the nerves that kind of come from the neck and go down into the arm. And we do think that probably has something to do with that. There's a lot of scapular weakness and it may be easier to injure those nerves. And so we do actually think that is more likely to happen in FSH. A problem with that group of nerves there, but thoracic outlet syndrome specifically, I'm not so sure.
What do you do to treat those nerve irritations or injuries in the body?
So I would probably look to bracing to help with the muscle weakness, but truly there's no specific treatment for having a nerve injury like that.
Mm-hmm. Here's another question. Any recommendations for pain treatment that comes from standing as opposed to walking? So and they say the pain is located in the back of the legs.
Just when walking, is that what you said?
No, when statically standing. So just standing becomes very painful.
Yeah, this is always hard. I mean, at that point, I would, if it's while standing, which, you know, probably doing quite a bit, it's probably good at that point to try one of the medications that we use for chronic pain. And then, like I said, just going back to trying some different bracing depending on the weakness in the legs or the torso to see if that might relieve some of that. But really it might be a good option to try some of the medications.
Here's a patient who says he's finding that chiropractic care has helped relieve pain and improve my gait. Has there been any research along these lines for dealing with FSHD?
I'm not aware of any research looking specifically into that, but I think that any of these things that are safe and that you find helpful is a good thing, and you should continue it. The only thing I would caution about chiropractic care is just to avoid the neck manipulation, at least.
Okay. Regarding scapular fixation, isn't the long recovery time required contributing to further muscle loss due to the inactivity?
I haven't really seen that. To be honest, the people who haven't had the people who I've seen who haven't had complications from it have been very happy with the outcomes and with the increased mobility of their arm. And I haven't seen that even with those weeks of mobility, that it necessarily will make people weaker in other places, like in their arm.
And I think there's probably quite a lot of physical therapy afterwards to
Yeah, absolutely.
Strengthen mobility.
Yeah, I wouldn't be concerned just about that period weeks of immobility.
Okay. Question about, I think this is probably another surgical procedure, tibialis transfer for foot drop. Have you seen that? And
I've seen that not in FSH so much, but I've just seen that in general. And I'd say, it's a great question. So I don't know that it would necessarily be helpful in patients with FSH.
Mm-hmm. I've heard of a patient who's thought it was helpful to her, but it's not nearly as commonly.
Yeah, no, it's not something that we commonly think about, to be honest. But that is interesting to hear that, and I think a good thing. I'll talk more to our surgeons and see what they think about that. The folks who actually do those surgeries. I don't know if they have been doing it a lot in patients with muscle disease.
Okay. Now we have some questions about supplements like CoQ10. Is that helpful?
Yeah, so I would say with these, there's not evidence to say that they're definitely beneficial, but there is, I kind of alluded to this study that looked at a whole collection. They gave patients a whole collection of antioxidants. And so I think that CoQ10 in general is a good thing to take, but it's not necessarily going to change anything. So it's one of those things where there's just not enough evidence to really recommend it, but it's definitely not harmful and may be helpful.
What about creatine and vitamin D?
Same story there, especially with the creatine. So creatine, I think, has been looked at previously, and again, didn't show any significant benefit. But theoretically, you think maybe you should see a little bit. So again, I think it's the same story as with CoQ10. We have no evidence that it really works. Doesn't seem like it would be harmful. So if you want to do that and it's not crazy expensive, then it's a reasonable thing to take those supplements.
And related, what about protein shakes? So just, I guess, making sure you have a lot of protein, is that?
Yeah, so yeah, same story. It wouldn't be harmful. I think one of the studies in the physical therapy literature did include supplemental protein with the aerobic exercise, and I don't think that also, I don't think that the protein necessarily showed that it was super helpful. But it's, again, one of those things where you're theoretically thinking maybe this is a good thing, definitely not a bad thing, but it just hasn't panned out when people have tried to look at it.
Yeah. And actually, this maybe relates a little bit to this creatine question, but on the sort of the blood test side, the creatine kinase levels have been way higher than standard. Can this be attributed to FSHD?
Yes. That's one question I can't answer. So yes. So that's an enzyme that just gets put into the blood as the muscle breaks down. And so that's that elevation in what we call the CK is just a generic thing that we see in a lot of muscle disorders as the muscle is breaking down.
All right, just now skipping, there's a question, what's the association between eyelid closure and FSHD, and does it always indicate that FSHD is present?
So in FSH, people have difficulty closing their eyes or have weakness in closing their eyes. So, when we look at it, we have a patient kind of squeeze their eyes shut as hard as they can and then try to see if we can open them. And it is a very common thing to have that eye closure weakness, but that is not necessarily, if you know somebody who just has eye closure weakness, that is not definitely FSH. So basically there are a lot of different causes for eye closure weakness. So that alone would not just be FSH. It'd have to be that and other things together, just because there's so many different causes of people not being able to close their eyes.
And many patients are bothered by, I guess, abdominal weakness that leads to a bulging belly, and women are always asked, are they pregnant and so on. Mm-hmm. Is there any way to address that or reduce it or support it?
Oh gosh, no, other than that, again, we showed that abdominal, that corset or the abdominal binder, and it's not going to help fix that. It's just, it's just a result of those muscles being super weak and not being able to hold in any of the fat with the muscles. So it is a problem, but I don't know of any other way I don't know of a way to fix that. And then the bracing is just gonna help support those muscles, but it's not a long-term fix.
Okay, and I think I have one more that's about symptoms and addressing them, and then we'll move on to a ton of questions about genetic testing and therapies that are on the way. So this individual said, what can be done about my shoulder pressing against my throat while I'm sleeping? It causes me to cough and sometimes makes it harder to breathe when I'm on my side. So I guess it happens when she's lying on her side and the shoulder displacement.
Yeah, I don't think I have a great answer for you. If you really like to sleep on the side, I don't think that there would be, unless you can, only you know best, but trying to find some way. I don't know if you could put a pillow in between there or something to help, but really I don't know of any specific way to help that.
Okay. So now let's go into questions about upcoming therapies, and particularly, if therapies that are being developed today are just going to stabilize the disease rather than reverse it. What's your...
Yeah, so great question. So all the therapies being developed today are trying to stop the disease progression. So however, I guess I would just look at it this way. To be 100% honest here, I think that the muscles that are super, super gone, so the muscles that are totally atrophied and you have almost no movement in them, I really do not think that those are going to be helped by the therapies that are coming out. So, and maybe a bad term, but I think in those cases where the muscles are totally atrophied, the cat's kind of almost out of the bag. There's no muscle left to save, essentially. That being said, I think that for sure these therapies are trying to stop progression, but I think that they're also, depending on the therapy, and hopefully we'll get a good one, if there's a really good therapy, I think that it actually could help with the muscle strength. So you then have muscles that are just kind of medium affected, that you still have strength in, but they're not totally gone. And in those muscles, I think there's muscle tissue left to save, and that could potentially be helped by the therapy. So I would say that I think with these therapies, there is going to be a potential to have improvement in your muscle strength, but I really honestly don't think that that's going to happen in the muscles that are just totally, totally gone, if that makes sense.
So another question, is there a correlation between the level of activity of DUX4 detected on muscle biopsy and the clinical severity of FSHD?
Not that I'm aware of. So DUX4 is super tricky. So even in patients with FSH, when they do biopsies all the time, they don't always even see DUX4 expression. It's even DUX. We keep talking about this variability in the disease, but even when they look at DUX4, there's variability in how it's expressed, how much is expressed, and I don't think it's just not that clear cut. Like there's a lot of expression and you have very severe disease. It's just not that clear yet.
Right. I think the person asking might have been referring to, say, the fulcrum biomarker study, where they're targeting muscle that appears to be, have a lot of water in it, might be inflamed, and they see histopathology indicating that immune infiltration. So
yeah, so yeah, that's true. So this is going back to, so try to bear with me here. So we talked about how this is a very slowly progressive disease, and then we talked about how some patients feel like there is this stepwise disease progression. And so when people started doing these MRI studies, they noticed a lot of the muscle has been replaced by fat, but then there are those places where you have things lighting up a little bit, or what we call this stir positive signal on the MRI. And people thought, oh, does that mean the disease is active when you see that stir positive signal? And that does seem to probably be true. That when that's happening, there you can see the DUX4 activity more easily, and that stir positivity does seem to indicate that, oh, the disease is active there. And then, in the back of our minds, we're thinking, well, does that have something to do with why people feel like this is more of a stepwise thing? Because there's kind of this disease is active and this other muscle, it's not active. But yeah, so I think that with that, there does seem to be some correlations between DUX4 activity and where you're seeing those changes in the muscle, but we really don't know much more than that.
Okay. People want to know, can you say more about DUX4? Does DUX4 expression ever turn on normally during the course of a person's life?
Yeah, so great question. And actually, let me see. I was going to see if I did have a slide a little bit about DUX4. I kind of had some hidden slides, so I was going to see if I can pull that up. I'm not sure if I'm going to be able to do that. It won't let me escape. Oh, wait, it did. Okay. So again, DUX4 in normal development is also, I think I've said this 1,000 times, so I apologize, but not completely understood. And it does have some normal, here we go. So let's see if I can pull this up. Can you guys see that? Sorry about this. This slide is a little detailed, but basically, yeah. So this is something that's normally expressed, we think, mainly in early development, and then we think that in general it's turned off. But to some degree, it is expressed even throughout life, and may be expressed in the thymus and the skin cells. But it's something that really people are looking into, and again, don't understand completely, but. And so I think people are looking into that, theoretically, if we stop DUX4 completely, is that going to be bad for any reason? And so that's something that's still being looked into.
Okay. All right. So people want to know how to get involved with studies. Where in Europe is the observational study, I guess, Resolve? Where is that being carried out?
It's in the Netherlands, and then in Italy, in Milan, and then in France, in Nice, I believe.
Yeah, and we have those locations posted on the FSH Society website, so you can look it up there and contact us if you would like to enroll. Okay.
And there's lots of, just as I said, there's lots of other studies happening in Europe around probably those same centers. So it's not just the Resolve study there too.
Some people are noticing that some trials have an age limit of 60. It says, I'm healthy, but 69. Is there anything for older patients to participate in?
Great question. So yeah, it just totally depends on the study. I'm sure there are studies that are enrolling over 60. So I think you just have to kind of look through everything that's out there, look at those lists on the FSH Society website, and kind of peruse clinicaltrials.gov, because there is really a lot, and I think that a lot of them probably you are gonna qualify for a lot of those that don't have that age limit.
Okay, this is a question I'm sure is on many people's minds, hearing about losmapimod. If it's already been tested and well tolerated, couldn't we just try it now while we have some muscle to keep? I know it's not orthodox. Pros and cons.
My understanding on this is no, just because it's not, I don't know that it's FDA approved for any indication right now. So, so I don't think that it's improved. So sometimes approved. So sometimes we do use drugs actually fairly commonly off label. So a drug that's already on the market and we're just using it for a different purpose than it was studied for. But I just don't believe this drug is on the market for anything, which is why it's not available for that purpose.
And I would also add, if anyone got their hands on the drug and tried it and happened to have an adverse event, which might have been caused by the drug or not, might be completely unrelated, that could be detrimental to the trial. Mm-hmm. So it's really important that these things be done in a, a really, because I it's possible it's available like in a chemistry library or something, and it's not even formulated for use, and things like this happen. So
right. And I mean, hopefully we'll know, I know that they're trying to be as fast as possible with this study. And so hopefully we'll have some information as soon as possible.
Okay. We have a lot of questions about genetic testing. So one is around, there are a lot of individuals who have clinical symptoms but have not been genetically diagnosed. The main obstacle is financial, insurance won't cover it. Mm-hmm. Is there help for people who need, financial assistance to get genetic testing?
This is where the genetic counselor is really good to answer these questions. Unfortunately, so with my genetics counselor here, we have not found a way to get around this in all patients. So of course it depends somewhat on insurance. So sometimes depending on your insurance, they will actually cover it. But the problem is when it's not covered by insurance at all, our experience is that the test is about, gosh, and I'm sorry if this is still, but the test is about $750 for the FSH1 testing. And we send our test to Iowa, which I think most people do. And there, if the FSH1 testing is negative, they're going to automatically reflex to the FSH2, and then it ends up costing at most about $1,500, which honestly, we have not found a good way around this for our patients. And so usually for us, it's just been coming down to whether patients want to pay for it or whether their insurance can. But sometimes, the other little way to get around it is that if you do have family members, kind of immediate family members who already have the disease, then entering a clinical trial, sometimes they'll let you enter it if you have the clear symptoms of the disease and have family members who have it, and then they do the genetic testing as part of the trial. But yeah, I mean, commercially, it's really hard, and it's been a problem. Now, I will say here at Ohio State, maybe I shouldn't say this, sometimes depending on insurance or whatever, sometimes our hospital will end up just eating the cost of it, but it just totally depends.
Okay, now we have, since it is often a familial disease, if you have an individual who's been diagnosed and they have children, grandchildren, siblings who might be at risk of also carrying the gene. So I assume these are, they don't have symptoms, but they may be too young, or they may be asymptomatic and could be at risk of passing along to their children. What is the recommendation for genetic testing, or how should people think about it, I guess? Right.
So I think that currently this is, I don't want to say this. I think this is a really personal question, and I think that different people have different opinions on this. But I'll give you my opinion. Is that currently, given the fact that we don't have any treatments that are disease modifying, and because this disease does not does not usually affect lifespan. We don't have to worry about a bad heart problem, which could sway me to say a different answer. But because of the way this disease is, without having those life-threatening issues and without there currently being a disease-modifying treatment, I guess to me, I would tend to leave it up to that person. So if you have a child, I don't think it's harmful to have them wait until they're old enough to kind of decide for themselves whether they want to look into it or not. Now, it's going to become more complicated when we do have treatment, and then I would probably advocate more strongly to get people tested at that point. But for right now, I think it's reasonable to let people wait and decide for themselves.
Right. But in order to make a decision, you would need to have a conversation with those family members.
Yeah, absolutely. And that being said, there is also research being done on people who are asymptomatic. So so if you wanted to join in those, or you really feel strongly about that, that's why I think it is really a personal decision.
Okay. So let's see. Here's somebody who has FSHD in their family. The son is 9 years old, asymptomatic. We don't want to do the genetic test yet, but knowing that there's a risk he could have inherited it. Is there any advice, beyond, to make sure he's, stays as healthy as possible in the event that he does have FSHD? What are the steps they can take to be proactive to keep him healthy?
Yeah, so I don't think there are any particular recommendations. I would just let him do what he wants to do at this point. I mean, we talked about how there's a 50% chance that he doesn't have it at all, and I wouldn't necessarily change anything or say he should or should not be doing certain things at this point.
As long as they're healthy things.
Yeah, exactly. Yeah.
Healthy diet, exercise, all those.
Yeah, we always love good diet, good exercise, but I wouldn't, nothing specific really.
Let's see. This, I guess, relates again to this genetic testing in children. But okay, this person has a daughter, has type 1 diabetes, she's 14, and her pectoral muscle presents with that horizontal line like the one you showed. Mm-hmm. She's a motivated swimmer, and doing a formal genetic test would be devastating for her. Would you recommend to do the test, or should I just wait? We don't know when the test should be done. Yeah,
these questions are so hard. Yeah, I mean, I guess if it were me deciding, I would still just say wait in that circumstance. If you really think that her knowing about it is gonna have a detrimental effect on what she does or how she's thinking about things, I think that waiting again is not a terrible thing. And then hopefully, again, I think that whole idea changes significantly if we have a great therapy, obviously. But in the absence of that, I think that I wouldn't personally push it or push to have the testing.
My goodness, there's so many questions. Let's see. Is there any research being done with stem cell based therapies? I guess we're talking about regenerative.
So there is some research looking at stem cells, but there's no clinical trials with or interventional trials with stem cell therapy at this point, but it is something that folks are looking into on a preclinical level.
Okay. There's still quite a few questions here about medications and various things, so maybe I'll jump back to that. This is another question we hear often. Are muscle relaxers or statins detrimental? I guess in the sense, could they speed up the disease progression?
So these are two different things. So muscle relaxants and statins are two very different drugs. So we'll start with the muscle relaxant. So this is usually stuff like Flexeril, tizanidine. I don't think that those are going to be harmful. Now, they obviously make people sleepy, and I guess theoretically they could make you feel weaker just while you're taking the medication, but I don't think that there's any concern about a muscle relaxant having a long-term harmful effect. And then the question with statins is a little bit more difficult. So statin drugs are the medications that people use to treat cholesterol. And so this often comes up because a lot of people are on statins or should be on statins for their cholesterol or heart disease or what have you. So again, I know you guys are thinking, well, nobody knows anything, but we really don't. So there has not been a great study looking into the effect of statins on patients with muscular dystrophy. So we don't know that there's necessarily an increased risk of statin use in a patient with muscular dystrophy. So in general, statins can have harmful effects on the muscle, harmful side effects. And this is in the general population. People can have problems with statin just ranging from a little bit of muscle pain to a lot of muscle weakness as a result of the statin. But again, that's just in the normal population. And what we don't know is if that particular risk is higher or is clearly higher in someone with muscular dystrophy. So in general, if a patient really needs a statin for another reason, like for coronary artery disease, then I think it's always a good idea to have that baseline muscle measurement, but really even beyond that, it's just watching people clinically and seeing how they do. And I would just be more likely to stop it with any sort of sign that something bad is happening with it. Because, yeah, a long answer. Sorry.
A couple questions here relating to testosterone. Has there been any testing in low testosterone with FSHD and fatigue and low energy? This person had this extremely low testosterone, and shots raised the level and made me feel better, more energy and less pain and discomfort. Mm-hmm. And then there's another question asking whether testosterone therapy does help with muscle strength and health.
Yeah, so there's a lot of people who say the same thing, that they feel like the testosterone does help with fatigue, especially, and maybe muscle strength. So I'm not going to answer that because there's currently a study that we're waiting to hear about that with Dr. Twill up at Rochester, that they're specifically looking at testosterone currently. So I think I'll hold answering that and wait and see what that shows.
Okay. And I was wondering when this question would come up, is there a role for CBD oil in pain management?
I think that everyone asks me that on a daily basis, not just with FSH, just everybody. And again, the short answer is that we don't know. I mean, there's no studies to kind of back our answers on. But I generally tell people that try it and see how it makes you feel. And there's no reason to believe, or that I know of to believe, that it would be harmful in any way to the muscle. And so it's really up to you. And I don't think there's a problem with at least trying it and see how, if it does have any benefit for an individual person.
Are digestive problems common with FSHD?
No, actually, it's not something that we commonly see with it.
Okay. What about incontinence issues? I see that discussed a lot in Facebook groups.
Yeah. So in general, I would say we don't think of it as a big problem, but I have seen people who have had that, and you just wonder if it's because there's pelvic floor weakness that leads to that. And so just recently, so there is actually physical therapy, pelvic floor exercises that can be done. So maybe that's something to consider in that situation.
Mm-hmm. So here's someone who has both FSHD and rheumatoid arthritis, which is very unfair to have both. And they have difficulty knowing what pain is from which disease. Is there a connection?
Yeah, I don't know that there would be any way to tell where the pain is from which disease, because a lot of the pain from FSH is also, people tend to have pain around the joints. So I don't know how you would tell the difference.
Mm-hmm. Okay. Let's see. Are there any studies in the role of stress and disease progression?
Not that I'm aware of, no. So, I mean, people have looked at cognitive behavioral therapy and it did show some benefit, but that's not exactly the same thing.
Mm-hmm. For those of us who cannot stand unassisted, would you recommend something like a standing frame or standing chair?
Yeah, I think a lot of people do find those super helpful.
Okay. And about, again, kind of the lordosis issue, are there any braces that you find particularly helpful, or should they be custom fitted, or any advice?
I think that most of the braces, I think there would be better if they were custom fitted. So usually the orthotic places, so around here it's the Hanger Clinic, has the custom fit, and I think those are probably the best option. And kind of what we discussed before, the abdominal binders or the lumbosacral corsets are probably your best option there.
Good. Okay. Let's see. I'm just, I think we have covered one way or the other most of the questions. And I think we are past the time that we had allotted. So I think I'd like to wrap up now and thank you so much for your time and sharing so much of your knowledge and here with us today.
Thanks, guys.
Okay.
I hope it was somewhat helpful.
It was, I'm sure. And I just want to mention we have our next webinar on, I believe it's Saturday, June 8th, and it's specifically on stance control braces, which many people are not aware of and some patients find very useful. So tune into that one. And for now, thank you very much and have a great rest of your afternoon.